Hello, everyone, and thank you for joining April's Clinical Education Series presentation. Today's presentation addresses pediatric medication diversion and how to prevent diversion across controlled substances and illicit drugs. I am pleased to introduce today's speakers, Greg Paramanchis, Lisa Sutton, and Adam Grana. Greg is a clinical pharmacist specializing in substance use disorder and REMS therapies. He works with providers and manufacturers to ensure safe, compliant medication use while supporting new programs and initiatives that improve patient outcomes. Lisa is a clinical pharmacy manager with Genoa Clinical Services. Lisa has been part of the Genoa team for nearly 5 years, bringing a background that spans both retail pharmacy and managed care clinical pharmacy. Her experience across these settings has shaped her passion for patient-centered care, collaborative practice, and executing clinical programs that improve outcomes. Adam is the pharmacy manager for Genoa Healthcare in Aurora, Colorado. He's been a pharmacist since 2017, working across long-term care, hospice, community retail, and mental health. He joined Genoa in 2022, where he focuses on optimizing workflow, delivering exceptional service to patients and clinic partners, and driving key performance indicators while maintaining strong collaborative clinic relationships. Without further ado, I will hand it over to Lisa to begin the presentation. Please take it away, Lisa.
Thank you, Shannon. Today we're talking about pediatric medication diversion, which refers to the intentional transfer of prescribed medications to individuals for whom they were not prescribed, including selling, sharing, or trading. While stimulant diversion in youth with ADHD is often the entry point for this discussion, a prevention-first framework requires expanding the lens to include all controlled substances, as well as the growing risk posed by illicit and counterfeit drugs. Adolescents are uniquely vulnerable due to neurodevelopmental factors, peer influence, and increased exposure to substances through school, social networks, and online markets. It's important to note that diversion does not imply inappropriate prescribing. Many diverted medications originate from evidence-based treatment, but we run into trouble when prevention safeguards are absent. Recent studies help us understand why a proactive approach must be emphasized over reactive responses. Although self-reported adolescent illicit drug use has remained stable or declined in recent years, overdose deaths among teens have increased sharply, driven largely by illicitly manufactured fentanyl and counterfeit pills made to resemble prescription medications. This disconnect highlights that the environment has become more dangerous even when use patterns appear unchanged. A prevention-first approach focuses on upstream controls, education about risks and legal consequences, right-sizing prescription quantities, safe storage and disposal, routine screening, and coordinated monitoring across clinics, pharmacies, schools, and caregivers. Pediatric providers and pharmacists are uniquely positioned to implement these safeguards because they interact with youth and families at multiple touchpoints. By embedding prevention into routine care, rather than waiting for red flags or adverse events, health systems can reduce diversion, protect patients from escalating substance use disorders, and prevent potentially fatal exposures. Prevention is not an adjunct to care, but a core patient safety strategy across all controlled substances and in the context of an increasingly toxic illicit drug supply. Medication diversion and misuse among adolescents is far more common than many clinicians expect, particularly among youth who have legitimate prescriptions. A 2025 systematic review and meta-analysis found that among individuals prescribed stimulant medications for ADHD, approximately 22.6% reported past year misuse. 18.2% reported past year diversion, and 17.9% reported lifetime diversion. These figures demonstrate that diversion is not a rare or fringe behavior, but a relatively common phenomenon within treated populations. We also know that stimulant prescribing has increased over the past 2 decades, especially among adolescents, expanding the pool of medications that could potentially be diverted if safeguards are not in place. Importantly, misuse and diversion are not limited to stimulants. National surveys indicate that prescription opioids and benzodiazepines are also commonly misused by adolescents, often obtained from friends or family members rather than illicit dealers. At the same time, monitoring the future data reveal a paradox. While overall self-reported illicit drug use among teens has remained stable or declined since the COVID-19 pandemic, overdose deaths among adolescents have risen dramatically. CDC analyses attribute much of this increase to illicitly manufactured fentanyl and counterfeit pills designed to mimic prescription opioids, stimulants, or benzodiazepines. This information reinforces the need to focus on prevention. When diverted medications circulate within peer networks, they can serve as a gateway not only to misuse, but also to exposure to counterfeit or illicit substances. Understanding prevalence helps normalize proactive prevention conversations with patients and families and justifies the routine use of screening, monitoring, and education as standard components of pediatric care. Diversion among adolescents is driven by a combination of demand side and supply side factors that intersect with developmental vulnerabilities. On the demand side, peer pressure plays a central role. Adolescents frequently report being asked by friends to share medications for academic performance, weight loss, recreation, or coping with stress and anxiety. Many teens perceive prescription medication as safer than illicit drugs, a belief reinforced by the legitimacy of a prescription label. Self-medication for untreated or undertreated mental health symptoms, such as anxiety or sleep problems, further increases their risk. On the supply side, surplus medication is a critical factor. Dose changes, medication holidays, early discontinuation, or automatic refills can leave unused pills in the home. Studies of prescription opioids have shown that leftover medication from a prior prescription are a major source of non-medical use among high school seniors, and similar patterns are observed with stimulants and benzodiazepines. Access points are often close to home, medicine cabinets, backpacks, and shared spaces where medications are not securely stored. Youth Perspectives research indicates that adolescents believe diverted medications are easy to obtain from peers, family members, or online sources. The current drug landscape amplifies these risks, and counterfeit pills containing fentanyl are increasingly sold as familiar prescription products. Prevention strategies must therefore target both sides of the equation by reducing surplus, securing storage, correcting misperceptions about safety, and addressing underlying mental health needs through appropriate screening and treatment. Next, we'll be hearing from Adam about warning signs and additional topics.
Thank you, Lisa. I'm going to be discussing some provider warning signs. Pharmacists and healthcare professionals play a huge role in preventing medication diversion and misuse. We have customer and patient-facing roles that are integral for identifying potential misuse. Pharmacists and other healthcare professionals can observe trends and behaviors that could represent possible misuse and diversion. Clinical red flags across controlled substances that can be seen in practice. Common red flags, especially as a pharmacist, repeated early refill requests, reports of lost or stolen medication, and requests for specific brands or doses could potentially be signs of diversion or misuse. Healthcare professionals can also observe behavioral and functional indicators, such as discrepancies between systems and functions, mood swings, social withdrawal, or declining performance. Healthcare professionals and pharmacists, it's important to utilize the tools that we have available, such as the prescription drug monitoring program, to flag potential risky behavior. This can help reduce potential medication diversion and misuse. Next, we'll be discussing some of the consequences of potential medication misuse and diversion. Failure to address diversion can result in significant acute and long-term consequences. Acute health risks vary by substance class, but this can include cardiovascular events, anxiety, psychosis, and seizures with stimulant misuse, respiratory depression and overdose with opioids, and sedation, agitation, and dependence with benzodiazepines. Chronic consequences include the development of substance use disorders, academic decline, legal involvement, and strained family relationships. Current counterfeit pill crisis magnifies these dangers. CDC data shows that from 2019 to 2021, overdose deaths among adolescents increased sharply, with the majority involving illicitly manufactured fentanyl pills. Many of these patients had no documented history of opioid use, suggesting unintentional exposure through counterfeit pills obtained via peers or social media. This reality underscores why prevention is critical. Once diverted medications circulate beyond the original patient, control is lost and the risk environment becomes unpredictable. Addressing diversion through education, safe storage, routine screening, and early intervention can prevent progression to misuse and protect adolescents from a drug supply that is increasingly lethal. Some prescribing trends and school collaboration. Communication is very important in preventing medication misuse and diversion. Environmental contexts play a significant role in the diversion risk. ADHD prevalence and stimulant prescribing has increased over time, particularly in adolescent populations. School-level analysis using monitoring the future data demonstrates that schools with higher prevalence of stimulant therapy subsequently also have a higher rate of prescription stimulant misuse among students. This association does not suggest that appropriate treatment should be reduced. Rather, it highlights the importance of embedding prevention where medications are present. Schools, clinics, and homes represent interconnected environments where access, norms, and supervision influence behaviors. Evidence from implementation studies shows that training pediatric providers in diversion prevention strategies increase the use of education, monitoring, and parent-teen communication. These findings reinforce that prevention efforts can shift culture and expectations before misuse becomes present. School-based prevention strategies are important to help minimize medication possession risks via nurse dosing and clear anti-sharing policies to support prevention. Caregiver roles in prevention are also integral in preventing medication misuse. One of the most important aspects is secure medication storage and monitoring adherence to prevent diversion. Collaborative communication amongst providers, caregivers, schools, families align expectations and that identifies concerns early. Restorative diversion programs could be a great alternative to punitive responses for substance infractions. These can be education-focused school programs that are an alternative to other disciplinary action. I'm going to pass it off to Greg now to discuss prevention strategies in the clinic.
Thanks, Adam. So like you said, we're going to start by talking off with prevention strategies in the clinic, and we'll move right in to risk mitigation through prescribing. Routine screening is a cornerstone of diversion prevention. The screening, brief intervention, and referral to treatment framework is recommended by the American Academy of Pediatrics for universal use with adolescents. Incorporating screening into routine care normalizes conversations about substance use and reduces stigma. When screening identifies risk, brief interventions using motivational interviewing techniques can correct misperceptions, reinforce protective factors, and engage caregivers. Screening should be paired with routine PDMP review for all controlled substances to identify concerning prescribing or dispensing patterns. Early detection allows providers to intervene with education, monitoring, and treatment adjustments before diversion escalates to misuse or exposure to illicit drugs. Next, we'll talk about reducing access through locking and disposal. And safe storage and disposal are among the most effective and evidence-based diversion prevention strategies. Multiple studies demonstrate that brief counseling combined with the provision of a lockbox or a lock bag dramatically increases the proportion of families who store medication securely. For example, interventions in pediatric emergency and community settings increased lock storage rates from under 20% at baseline to over 70% within weeks. Secure storage limits access by peers, siblings, and visitors, directly reducing diversion and accidental ingestion. Disposal education is equally important. Families should be informed about drug take-back programs and safe disposal methods to eliminate leftover medications. These strategies are particularly critical for opioids and benzodiazepines, which are commonly obtained from household sources for non-medical use. Framing storage and disposal as routine safety behavior reinforces prevention as a shared responsibility between clinicians and families. Next, I'll talk about responding to suspected diversion and our process by which we do that. In the next slide, we'll see non-judgmental safety-focused interventions. Clinic-based prevention strategies focus on reducing opportunity and increasing awareness. Education is foundational. Patients and caregivers should receive clear counseling on their health and legal risks of sharing medications and on the dangers of counterfeit pills. Treatment agreements can formalize expectations and support consistent messaging. Prescribing strategies include preferring long-acting or abuse-deterrent formulations when appropriate, prescribing the smallest practical quantities, and aligning refill schedules with follow-up visits to minimize surplus. Routine PDMP checks and documentation support safe prescribing across controlled substances. When opioids are prescribed or accessible in the home, co-prescribing naloxone and providing overdose education can further reduce harm. These measures are not punitive. They're standard safety practices equivalent to seatbelts or childproofing. By integrating prevention into everyday workflows, clinic can substantially reduce diversion risk without compromising access to necessary treatment. Next, we'll talk about integrated workflow and care-based applications. So looking at non-judgmental safety-focused interventions, there's patient engagement, which prioritizes non-judgmental, transparent conversations and exploring medication use, peer pressure, and mental health needs. Tailored treatment reassessment, reassess, diagnose, and treatment goals, screening for co-occurring conditions to personalize interventions. Risk-based monitoring, using pill counts, urine screening, and PDMP monitoring selectively based on patient levels. And coordinated care support. Coordinated care with behavioral health services document care to maintain continuity and prevent escalation. So, where we're co-located within the clinic and the pharmacy prevention, integrated prevention workflows, co-located clinics and pharmacies align roles and communication to enhance preventative care, efficiency, and effectiveness. Routine monitoring and feedback includes system checks, PDMP reviews, and feedback from caregivers and schools to reinforce safe practices. The pharmacist's role in monitoring refill patterns, counsel patients, and identify discrepancies to support prevention efforts. Quality metrics and communication, the screening rates and PDMP usage with clear providers and caregiver communication ensures continuous improvement. Peer-based applications, so there's some risk identification. Scenarios can highlight risk factors including peer pressure, medication diversion, and academic challenges. Prevention strategies include private discussions, screening tools, caregiver involvement, and medication monitoring. Medication management of switching to long-acting formulations, supervised dosing, locked devices, and school coordination improve safety. And follow-up and support. Closely follow-up reinforces monitoring, supports the patient, and maintains therapeutic relationships. And the key takeaways: when diversion is suspected, the response should prioritize safety, transparency, and continued engagement. Non-judgmental conversations that explore medication use, peer pressures, and mental health needs are more effective than confrontational approaches. Reassessment of diagnosis and treatment goals combined with screening for co-occurring substance use or mental health conditions help tailor interventions. Options may include switching to long-acting formulations, reducing quantity, increasing visit frequency, or considering non-stimulant alternatives when appropriate. Pill counts, urine screens, and other close PDMP monitoring can be used selectively based on risk. Documentation and coordination with behavioral health services support continuity of care. Early prevention-oriented responses can interrupt diversion trajectories and reduce the likelihood of escalation to substance use disorder or illicit drug exposure. And with that, I'll turn it back to Shannon.
Great. Thank you so much, team. This concludes today's clinical education series presentation. Thank you all so much for joining. Next month's presentation will navigate the topic of treatment-resistant depression. Please stay tuned around mid-May for this content. It will be available on our YouTube channel along with all of our other presentations listed on the screen at www.genoahealthcare.com/center-partner-resources. Thank you again and have a great day.